as well as some of the other resources I wanted to talk to you about. Let's go ahead and I'm going to talk to you about the PowerPoints that I had uploaded. In order to understand some of the things that you're going to be looking up for your assignments, you've got to understand some of the terminology that we're talking about with respect to drugs and pharmaceuticals and pharmacology. So the first PowerPoint gives an overview of some of the key terms, and I'm just going to go through and explain to you so that you have a better understanding of when we get to our application of why it's important to know these things, you understand the concept. So when you hear talk of drugs, you hear of what are called pharmaceutic phases. There are two pharmaceutic phases to drugs, and they are called disintegration and dissolution, okay? Disintegration is when you have the client has ingested a tablet, and it has to break down into particles that disintegrate so that it can get dissolved to get delivered into the system. So it sounds simple enough. It's disintegration and dissolution, the two phases of the pharmaceutic phase. The word pharmacokinetics encompasses 4 distinct aspects with regards to drug and pharmacology delivery. And you'll see this abbreviation here, ADME, A-D-M-E. What this stands for are the different phases of pharmacokinetics. Absorption, I'm going to go ahead to the slides, then I'll come back. Distribution, metabolism, and excretion. So pharmacokinetics tells us a little bit more about what's happening to the drug. What changes, what's it going through once it gets delivered into the client. So the first one, absorption. It's the movement of the drug particles from the GI tract to body fluids. It can be affected by blood flow in the intestinal tract and multiple factors that affect the gastrointestinal tract as well, such as stress, hunger, fasting, foods, acidity, the pH of the intestinal fluids, or any underlying gastrointestinal disease. When we're talking about absorption, we also have to remember that not all drugs go through the GI tract. So when we're talking about, pills or liquids that clients take orally, those are going through the GI tract. What other ways can drugs get into the body?
Respiratory.
Respiratory, yeah. What do you call it when it's given via respiratory? What's the modality of delivery? Like the client is using what?
The lungs.
The lungs.
Inhalation.
Inhalation, yep. So they might be using an inhaler or a nebulizer. Very good. What's another way you can get a drug in?
IV.
IV, exactly. What's IV stand for?
Intravenous.
Intravenous. And then I see IM. Everybody know what IM is?
Intramuscular.
Intramuscular. What's sub-Q? Subcutaneous, under the skin. Yes. And there's also intradermal. You will be learning these skills through upcoming labs. But topical, yep, excellent. We're going to talk about topicals as well. So there's multiple ways that drugs can go through absorption based on the way that they were delivered. When drugs are going through the system and getting absorbed, you need to be comfortable with a term called the first pass effect. Or you'll hear it in the literature, it's called the hepatic first pass. This is where some drugs pass from the intestinal tract to the liver before they get circulated to the end systemic area through the circulation to get delivered to where they need to be. Some drugs have a stopping point where they go from the intestinal tract to the liver first. And we'll talk more about this when you learn about the specific drugs that this applies to. A lot of this is overview here so that when we move forward into the different drug classifications, you're able to understand some of the terminology. So if you hear me saying we'll cover this more, it's because we will. This isn't the only time that you're going to hear these things, but without an exposure to them, you won't have understanding. I love it. Somebody just, Lori added suppository as one of the vehicles of delivery, and yes, you will be covering suppositories as well. So that's given either you can give suppositories vaginal or rectal. And we'll talk about, there's eye drops, ear drops, nasal sprays, nasal drops. So you'll learn all these different modes of administration. All right. So another thing, sorry if I get distracted when I see the chat box light up. Another term you need to be familiar with is bioavailability. It's the percentage of drug that reaches the systemic circulation. This is affected by multiple factors, such as the drug form, the route or the route that it was given, the gastrointestinal integrity, the motility of the GI tract, foods, other drugs, changes in liver metabolism, or liver blood flow. So a lot of variables, come into play when we have a drug that we are administering. That is why it's so important to understand all these features. And then on top of all the things that the variables the drug has, there's all these variables that the client has. So it's so important because no drug is going to, react or have the same effect among different clients because of all the variables that we need to be aware of. So these are some of the key terms you need to understand when we're talking about drugs absorption. Then we're going to talk about the pharmacokinetic stage of distribution, the process where the drug becomes available to body fluids and tissues. So it came from a bottle on the shelf, went in through the route that it needed to go to, but now it's got to get to the body fluids and tissues. Only free drugs, which are drugs not bound to proteins, are active and can cause a pharmacologic response. We'll talk more about this, again, with regards to specific drugs, but I want you to have this visual that, based on whether the drug is protein bound or not, based on blood flow, whether it's a blood flow in the GI tract that has to do with how the absorption is going. As the starting point, we've got blood flow also as a variable when we talk about distribution, as far as a factor of, hey, is how fast or how slow or how effective or ineffective is that drug going to get to where it needs to be? And then once it gets circulated or delivered to where it needs to be, what's the tissue like where the drug is going to? So we call that the body tissue affinity. Is the tissue receptive to the drug that's being delivered? All these variables produce a pharmacologic effect, and it's either going to be a desired one where the client has a good result when they're reevaluated, or it may be something that has to be modified because based on the factors of the drug and the client, it's not the right drug and we need to do something different. This is where the nursing process comes into play hugely to find out, based on our client assessment, what's their diagnosis, what drug are we using, and when we go back and do the reevaluation, are we having the right pharmacologic effect? So the purpose of this talk, too, is just to get you aware of all the variables and dynamics that play part in this whole drug process. So more pharmacokinetics, we said it was ADME. So we had absorption, distribution. Now we have our metabolism. Metabolism is where the body inactivates, or you'll hear the word biotransforms. It transforms it into something inactivated. So the body inactivates or biotransforms drugs. You need to know that the liver is the primary site of metabolism. So based on a person's liver function, we could have problems with the dosing of the drug that they're getting if they're not breaking that drug down. And one of the things that we'll talk about specific to this metabolism is something called drug toxicity. We'll get there. I gotta keep in order here. So I get excited. I want to say it all. Excretion, which is the final phase of the pharmacokinetics, or final area of the pharmacokinetics that we're going to talk about, is also called elimination. The kidneys are the main route of elimination. However, you can also have drugs eliminated through the bile of the liver, the stool or feces, lungs, exhaling it, breathing it out, sweat, or breast milk. We will spend time learning about some of the key lab values that we associate with drugs and drug function, as well as function of excretion. But with kidneys being the main route of excretion, please make sure you are aware that there are lab tests specifically relating to the function of the kidney called the creatinine or creatinine clearance. You'll also hear blood urea nitrogen. Younger nurses call this the BUN. In my day, we weren't allowed to say the BUN. It was the blood urea nitrogen, or the BUN. and then glomerular filtration rate, or the GFR. These are lab values that indicate a client's kidney function. And if you have a drug that you're giving and you know that it's excreted primarily through the kidneys, and you have a client that has impaired kidney function, what do you think bad about that? Yeah, they can't get rid of it. Exactly. Good. So you guys are with me then, understanding a little bit about this whole, look at the big picture. The next word I want to expose you to is pharmacodynamics. So pharmacodynamics is the name that's given to the specific study of the way drugs affect the body. I put Benadryl up here because, again, I try to pick drugs that you're not afraid of. Like, oh, yeah, Benadryl. You probably have some in your bathroom or your kitchen cupboard, wherever you keep your meds. You probably got some. You've probably taken some. You've probably given some to someone at some point in your life. But a good example that I wanted to give you for Benadryl is, study of the way drugs affect the body. You want to make sure that you understand the terminology primary effect and secondary effect. So the primary effect is the desirable effect, or what the drug is supposed to be doing. Benadryl is the brand name of a drug, which I'll spend more time talking to you about brand and generic. Diphenhydramine is the generic name. So when drugs are listed, you'll see a name with a capital letter. This is the branded name. The generic is in lowercase and usually in parentheses, diphenhydramine. NCLEX and usually ATI questions, and I know NCLEX, they use generic. The reason we try to teach you both, or we do teach you both, is because in common language, you need to know both. So a client is not going to know, more than likely, diphenhydramine, but they're going to know Benadryl. In the nursing world and in the professional world, you're going to need to know both as you communicate about these. So what's the primary effect of Benadryl? Antihistamine. So the antihistamine is its primary classification. The primary effect of an antihistamine, you see some of the things listed here. It's supposed to help with sneezing, itchy, watery eyes, runny nose, itchy throat. Okay, so this is good. We want it to help with all those symptoms. That's the primary effect. What's a secondary effect of Benadryl that you know of that may be desirable or undesirable? And I already see the answer in the chat box: sedation. Exactly. So drowsiness. Exactly. So there are situations where, yeah, we wanted to do all the things listed here, but let's say we have a patient who has allergies and they're up all night sneezing and itching. It's not a bad thing then if they get a secondary side effect of drowsiness or sedation, that it helps them get a better night's sleep. However, if they take it in the day and they get the primary effect where these symptoms are alleviated, but they get a secondary effect of drowsiness and they have to be driving or operating machinery, that's not a desirable effect based on that context or that situation. So we want to make sure that we're keeping it in the context. Yeah, hyperactivity in children. One of the students typed in, Lori has typed into the chat box here. And I'll tell you, this brings up a point. There are exceptions to every rule on every drug. So typically we say, oh, Benadryl makes people sleepy. No, they're in children or some clients. They have hyperactivity from Benadryl. Kevin's saying, give it to your dog for a road trip. Exactly. So that's a desirable effect of sedation. Again, we have to keep it in the context of what we're doing. So your language will change because what I'm basically, the terminology that I'm telling you, I'm using the word context. Your way of finding out the context is going to be by doing a nursing assessment and finding out, what are the components that I need to be aware of the situation, not only pertaining to the drug, but the situation or the context to the client and the scenario that I'm using it in. Whether it ranges from the primary and secondary effect, whether it ranges to their lab value, whether it ranges to the symptoms you're using it for. All this starts to kind of culminate together and help you understand how you should be studying when you're going through these drugs. So, good. Thanks for your interaction. It's nice to see this chat box light up. I don't know why you guys don't have your audio on and are talking to me. Some of you do. Don't be shy. All right, pharmacodynamics, another thing we want to talk about. The pharmacodynamics is the terminology that's given to talking about the onset, Peak and duration of action. Okay, I'm laughing because the chat box is lighting up with students are responding things like they don't have, the kids aren't at school today, so they have screaming in the background. So, okay, I respect that. Mine were told to be super quiet during this course as well. All right, so pharmacodynamics, we're talking about learning a little bit about the onset, peak, and duration of action of drugs. This has a lot to do with the response to the dose and what is called the maximal efficacy. Different doses give different response based on different factors within our client. So you can have a client because maybe based on their body size or their kidney or their liver function or their sensitivity to certain medications needs a lower dose to get the same job done than a client who may have a larger body habitus or better kidney function than the elderly frail client that I was maybe describing a few seconds ago. So dose is important, but you have to be aware of some of the things that we talk about. So basically what this little thing is showing you is that the main phases of drug action are onset, peak, and duration. And for different drugs, and this I'll show you how to find this in the Davis Drug Guide. When we're talking about drugs, the onset is when it starts to work towards the peak action. Peak action is when the serum concentration is at its highest level, giving the most highest chance or maximal efficacy of the drug action. And then it starts to taper down until it is eliminated, and this is called the duration. So we have when does the drug start to work, when's its peak effect, and how long does it last? And we'll talk a little bit more about those. There's another slide. Some other terminology is called the Therapeutic Index, okay? This measures the margin of safety of a drug. It is a ratio that measures the effective therapeutic dose and what's called the lethal dose. Drugs that have what's called a narrow window of safety or a narrow margin of safety or a narrow therapeutic index or a low therapeutic index, they're depicted in this graph up here. There is not much room for error in your dosing here because if they accumulate a high amount in the blood system, they can have toxic side effects and lethal side effects from the drug. We'll talk specifically about drugs that have known toxic levels, and with these drugs, there's certain blood or serum levels that are monitored. You'll hear of digoxin toxicity, or you'll hear, hey, what's their dig level, their digoxin level? What's their dilantin level? What's the Depakote or the valproic acid level? You'll hear about different blood tests as we move through the different classifications, but you need to have the understanding of that these drugs have a low therapeutic index, and if you have a serum level that's accumulating and are stacking up more doses of drug on top of it, you could be doing harm to your patient. This is a visual schematic of a high therapeutic index, okay? A high therapeutic index drug has a wide margin of safety and it has less risk of drug toxicity. So this will be applied specifically to certain drugs as we move forward in the classifications, but I want you to have an awareness of what it's talking about. Peak and trough, we're going to get to. So Catherine typed in peak and trough levels, which are a way that we can monitor how the blood levels are in response to how they, or in comparison of how they should be for the normal dosing and clearing of medications from the system. And my next slide here happens to be peak and trough. So these words, peak and trough, they are correlated to peak is the highest serum or plasma concentration of drug at a specific time. It indicates how the rate of absorption of the drug. A blood sample is drawn at the proposed peak time according to the route of administration. So a client gets a drug based on what drug it is. There's a set parameter of, hey, now check a level in their blood and see if what the peak level is in the client's body based on what the literature says it should be, and let's find out if they're in a safe range. A trough drug level is the lowest plasma concentration of a drug. It measures the rate at which the drug is eliminated. Trough levels are drawn immediately before the next dose of drug is given, regardless of the route. The main thing that you'll see in clinical settings are something called a vancomycin peak and trough level. These are blood levels that are drawn at respective times based on, how the drug should be processed and absorbed and eliminated in relationship to the time that it was given, and the expected normal levels are compared to the client's levels that are drawn. Based on the levels that are obtained, the drug either may need to be, the dosing of it may need to either be increased or decreased. And when I say dosing, I'm talking about the strength of the drug. Everybody still with me? If we need a break, tell me. I mean, I'm just going to keep going, but yes, so far so good. Thanks, Heather. All right, the next slide talks about loading dose, another key term you need to be aware of. A loading dose is that a client will get a certain dose of a drug that is higher than the normal routine or maintenance dose that they're going to be taking. And this is needed for certain drugs where we want the client to have an immediate response to the drug, and it's a drug that has a safe profile of being able to do that. So one of the drugs that I have an example on the slide here is called digoxin. Digoxin is a cardiac drug, and I'm not expecting you to know that that you were supposed to know that at this point in time, but I'm using it as an example because it is a key cardiac drug that you will know. And I have in here in parentheses, slows and strengthens the heart. You will remember from this point forward the chant that digoxin slows and strengthens the heart. I can still hear my nursing instructors teaching me slows and strengthens the heart. But digoxin is a cardiac medication that is used for certain cardiac conditions where we want it to slow and strengthen the heart. We'll get into those in our cardiac lecture. But digoxin is a medication that can be given, clients can get a loading dose. One of the key things, let's say they have congestive heart failure and they have weakening of their heart. We want a drug that's going to slow down and strengthen the heart. They get a loading dose of digoxin to help get them out of trouble from their congestive heart failure, in addition to other medications that are given. But this is a medication that we talk about with regards to loading dose. So the client gets a large initial dose. And when I say large, I'm not talking lethal. I'm talking larger than their maintenance dose, which is known as the loading dose of a drug is given to achieve a rapid minimum effective concentration in the plasma. Then they get on a maintenance dose, which is then referred to as their prescribed daily dosing or their routine dose that is ordered. So loading dose is when we want the drug level to get to the concentration of where it's going to have its efficacy sooner than just having the client take their daily maintenance dose to build up the bloodstream, in the bloodstream. All right, some other key terminology. Side effects. Side effects are the physiologic effects not related to the desired drug effect. All drugs have desirable or undesirable side effects. And we talked about this when we were talking about the Benadryl. Physiologic effects that are not related to the desired drug effect. So a side effect that we talked about for Benadryl could definitely be the sedation or the insomnia or the hyperactivity. You need to know this terminology as we extrapolate it from the Davis Drug Guide. The difference is in the terminology adverse reactions. They are more severe than side effects. They are a range of untoward effects, which are unintended or occurring at normal doses of drugs that cause mild to severe side effects. You might have heard the word anaphylaxis. It's cardiovascular collapse. The system shuts down, okay? And the person has what we call an anaphylactic reaction or anaphylactic shock. So adverse effects or adverse reactions are more severe than side effects. A client may tell you that they take their medication and it gave, like an antibiotic, it gave them a little bit of nausea. Based on the severity of it, it's not necessarily an adverse reaction, it's just a side effect. And sometimes with certain medications, having a client, if they are able to take it with food, we can offset the nausea that they were complaining of. So adverse reactions are definitely more severe than side effects. They are always undesirable, and they must always be reported and documented because they represent variances from planned therapy. Toxic effects or toxicity, these are identified by monitoring the blood levels for the therapeutic range of the drug for specific drugs. Not every drug has a drug level associated with it. Only drugs that have the narrow therapeutic index are ones that we monitor. Wide therapeutic index, this is, what I was saying, therapeutic ranges are seldom given. So there are certain antibiotics, certain medications for seizures, digoxin I had mentioned. These are examples of drugs that have a narrow therapeutic index. So the ranges are monitored closely. Drug level, if a drug level exceeds the therapeutic range, toxic effects are likely to occur from an overdose, meaning they've got too much of a dose and their dose needs to be decreased, or the drug could be accumulating because their body is not eliminating it or excreting it the way that it should be. And perhaps that's related to some underlying kidney or liver dysfunction that the drug's accumulating in the system because the body's not able to filter it out. Pharmacogenetics. It is the name given to the scientific discipline studying how the effect of a drug action varies from a predicted drug response because of a person's genetic factors or hereditary influence. One example is that African American clients do not respond as well as Caucasians to certain classes of medications for high blood pressure or antihypertensive meds, such as ACE inhibitors. So I don't expect you to know what ACE inhibitors are at this point. I'm just giving you an example that certain genetic factors do affect the way that drugs can be going through the phases of pharmacokinetics. Two other words you'll want to know: tolerance. Tolerance refers to a decreased responsiveness over the course of therapy, and another word is tachyphylaxis. So tolerance is when you've been giving a client a medication and all of a sudden they need a higher dose to get the job done. What do you think is a common category of medication that clients develop tolerance to? Opioids. So yes, pain medication, narcotic pain medication. And this is something that we have to be mindful of because it is it's a problem. If you have a lot of times clients on opioids, they need a higher dose because they've developed tolerance where there could be preconceived thoughts that, oh, they're just drug seeking or they want a higher dose. But tolerance is definitely a phenomenon that happens that we need to be mindful of with certain classifications of drugs. Again, when we get to those classifications, we'll plug in the concept of tolerance as it pertains to that drug. Tachyphylaxis is a rapid decrease in response to the drug. So it's basically what we call an acute tolerance. And drug categories that cause tachyphylaxis include, they can be narcotics, barbiturates, laxatives, and certain psychotropic or antipsychotic medications. So this is when you had a drug that was working and then all of a sudden the client needs a significantly higher dose to get the job done over a short period of time, where tolerance refers to over the course of therapy. All right, placebo effect. This is when a client is getting a psychological benefit from a compound that may not have the chemical structure of a drug effect. Placebo is effective in approximately 1/3 of persons who take a placebo compound, and this you'll hear about placebos in the context of drug trials. We don't tell clients we're giving them something that is not really what it is. The context of the terminology for placebo is in drug trials where the client had the study or the provider has an ethical obligation to inform the client they may be receiving a placebo, and the client signs it.
No, that'll be fine.
So, as a summary, I've got a couple of visual slides here.
She'll be coming around the mountain. She'll be coming around. She'll be coming around.
Here's some background noise. I think it's Dominique.
Sorry.
Are you able to mute? No.
Yeah, I just came in. I'm sorry.
Okay, that's okay. Thank you.
Oh, shit, looking like that.
So phases of drug action, this just kind of is basically looking at another visual representation of the slides that we reviewed. We have our pharmaceutics, our pharmacokinetics, and our pharmacodynamics. These all align to give us the phases of drug action. And again, variables that we talked about, what form is it in? We talked about the pharmacokinetic phases, and then we talked about the variables that affect the pharmacodynamics. Okay, I was just going to see who was that. Good. All right. And then determinants that affect drug therapy. Another visual representation of some of the things that I've been talking about where, we've got this drug. The drug alone is going to work differently based on what dose it is, what time you're giving it, what condition you're giving it for. But then you've got all these factors, you know, individually pertaining to the client, the clinical factors. You've got factors pertaining to the administration. You've got factors pertaining to the pharmacokinetics, and you've got factors pertaining to pharmacodynamics. All of these are variables that play into effect on how your drug is going to work, okay? So these are all determinants that affect drug therapy. Without having a general overview to these, if I told you to go start reading the Davis Drug Guide and look up the classifications for the drug, a lot of this isn't going to make sense to you, and we will build upon this, but you have to have a basic foundation of the understanding of these principles. One of the other things I just want to point out to you is the time intensity involved with the drug approval process. I'm not going to read all these to you, but if you look at each of these distinct phases that a drug goes through before it gets FDA approval and gets to manufacturing, we're talking ranges of up, you know, this could be up to 10 years, up to 6 years, up to 7 years, up to 2 years. So drugs go through much discovery and development and preclinical research and development and clinical trials before it even gets to the point of the FDA reviewing it. So be mindful of the fact that this is a lengthy process that costs a lot of money. Pharmaceuticals is a big industry in our healthcare world. And even after drugs are approved, many times they're recalled because the way that they were studied during clinical trials didn't pan out based on how it was tested on certain subjects. It didn't pan out to when they gave it to a certain population. When we go through certain drugs, I'll be talking to you about some of the, you know, consequences that we have or findings that the literature has identified with regards to specific warnings that are put on drugs after they're manufactured. And we'll plug those more. But again, want you to have an awareness of the drug approval process. Drug names. I have another slide that comes from the Davis Drug Guide where I'll also allude to this, but and I showed you this when we have the Benadryl. We have chemical names, generic names, and brand and trade names. Our Benadryl box showed us the generic and the brand name. The generic is the non-proprietary name for the drug, universally accepted, and the brand name is the proprietary name chosen by the drug company. Chemical names are it's basically a chemical name that's given to describe the drug's chemical structure. A lot of times you'll see this in the patient information leaflet that comes with the drugs or while the drug is still in its investigational stage. We commonly don't use these in our nursing language. We're using generic and brand or trade names. Here's the good old nursing process, okay? And you've got to remember ADPIE. And it stands for Assessment, Diagnosis, Planning, Implementation, and Evaluation. If you begin to study your nursing material with the nursing process in mind, you will have better application and understanding of it to client scenarios, which is ultimately the way NCLEX questions are presented to you. They are presented in patient scenario situations where you are challenged to make sure that you are understanding how to apply the knowledge that you have gained to scenarios pertaining to the nursing process. This will make more sense as we move forward, but please pay attention and be aware of this ADPIE. These are general, helpful points to remember that we teach our clients to take medications as prescribed. If they have questions, they need to reach out, call their provider. Keep medication in an original labeled container and store as instructed. A lot of times clients don't want to carry around multiple pill bottles, so they dump all their pills into one bottle, and then they're really not sure what's going on. Keep all medicines out of reach of children and pets for that matter. My friend's dog just got into a prescription bottle of it's prescription fish oil. It can be prescribed for high cholesterol, and he ate the whole bottle. So yeah, he had to have some major intervention done, and he was having some major explosions. So children and pets. And I'm not saying that to be, I guess I'm using this as a funny situation because her dog turned out fine, and it was just a very big, messy disaster. But obviously drugs that, you know, could get ingested by clients or children or animals, or a client overdosing, taking the wrong medication could be fatal or lethal. So I don't mean to belittle that in any way. Remind grandparents and visitors to monitor their purses and luggage when visiting, and that, you know, for the same reason. Checklist for health teaching and drug therapy. Comprehensive drug health history. You want to make sure that you understand what your client is taking as well as their medical history. Reasons for medication therapy is something we want to teach. Many times clients have no clue why they're taking it. My doctor told me. We want to make sure that our clients know why they're taking a medication. And part of what makes us a better nurse is that if we can explain it to our client, we have to have an understanding of it. So it's like a double checkpoint. We want to make sure that we're teaching expected results, side effects, and adverse reactions, when to notify the healthcare provider or pharmacist, and we want to make sure that we are mindful of interactions with other drugs, foods, maybe some laboratory testing the client's going to have done, or some environmental interactions. Checklist for health teaching and drug therapy continued. We want to make sure sometimes when clients take certain drugs, yeah, drug herbal also. Good point, Catherine. I just saw it pop up in the chat box on this last slide. We will be going over drug herbal interactions as well. I should add that in there. Drug herbal. Good point. Certain medications, the client may have to change their activities of daily living. Like if they're taking the Benadryl and it's making them sleepy, they're not going to drive while they're doing it. Maybe they're taking a diuretic, a water pill, and they got to get up at night, or they're taking it at nighttime, which they shouldn't be. They should be taking it in the morning. But maybe they have to get up to go to the bathroom at night, and it's increasing their risk of fall. We need to be mindful of, hey, what do we need to be thinking about with regards to activities of daily living and the drugs? We will focus specifically on demonstration of teaching and learning methods. Some clients learn well by listening, discussing, and there is what's called the teach-back technique, which is where the client gives you a return demonstration of the actual skills. We'll talk specifically about teach-back, and one of the key examples is when clients are learning to deliver insulin. And then the medication schedule, being mindful of certain activities of daily living and related drug level of action. So if it's something that needs to be taken at a certain time, let's say it's a pain medication and they know that they have a physical therapy appointment coming. Maybe they have to be mindful of taking that medication to where it's going to have its peak action during their physical therapy session. So things can be, medication schedules can be modified based on when you want results to occur. We're almost through this slide set, and I think we will probably take a little break just so that I can break up the presentation here. But I'll finish with these, and then we'll take a break. Checklist for health teaching more. We want to be mindful of how are the drugs being recorded. Sometimes clients need to record, their blood sugar in relation to the dose of medication that they are administering. We need to be aware of any other equipment associated with monitoring the medication. So I just mentioned, for certain blood sugar, they need to take an AccuCheck based on figuring out their insulin dose, perhaps. So what other equipment do we need? Development of support and backup system. Is there anyone else that is with the client that we can teach the material so the client has a backup? And then be aware of community and financial resources. All right, we have a couple of practice questions here. We're going to talk a little bit about goals. We teach nursing goals should be called SMART goals, which is a goal that is, the acronym SMART stands for simple, measurable, agreeable, realistic, and timed. So without even having a full course on SMART goal writing, take a look at these and let me know what you think. Oh, the answer's on the bottom. I think you can see it. All right, I blew that one. The answer to this one is D, and now here you have the rationale. It meets the criteria of all the SMART components. I didn't realize the answer was down there, and I think it's going to be on them for all of them. All right, well, you'll get 100% on these questions. Practice question 2, without looking at the answer, if you can, avoid it. Which information will the nurse include in the patient teaching? This question's in here just to also let you know with select all that apply questions. These are questions that make nursing students crazy. So you want to make sure that you're reading each statement as a true or false in response to the question that was being asked. That many times helps you filter out if you're not quite sure how to look at the question. Yes, crazy. Yeah, nursing student, select all that apply, and this is a more of a basic select all that apply. You'll hear students, they don't like select all that apply questions. It's something with practice you will get better at. So here, the only one that you're not going to discuss with your client is cost of drugs. Cost of drugs, that varies on, factors that we don't know about. We don't know about our clients' healthcare resources. We don't know about their insurance plan. So that's not something that we would, get involved in. But the other areas we are covering when we're doing teaching. And then this one everybody should get right, which is the first step of the nursing process, assessment. So remember that ADPIE, okay? All right, we got a couple more slides. I might as well go. This, I believe you covered in lab. Here we have what are called the 5+5 rights of drug administration. Certain textbooks will tell you 5, some will tell you 7. We are teaching you there are 10 rights of drug administration. Here we make sure that we have the right patient, the right drug, the right dose, the right time, and the right route. I have these pictures on here because if you do have a client that mixes up their pills and you need to, it didn't come in the bottle, they didn't bring you the bottle, or they don't have it in the bottle that with the label, the prescription label on it, or you need to verify is that in fact the correct bottle that it's in, you can look up pills. There's apps for phones, there's apps on the computer. You can type in, green pill with N on one side and 15 on the other, and it'll pull up a list of drugs that match that criteria, and you can match it up to see what the drug is. Some drug guides have pictures in them. Here it's showing you that for the drug Ambien, the trade name is Ambien, Zolpidem is the generic, and these are different strengths, 5 and 10 milligrams. It shows you what the pill looks like and what's marked on it. So there are ways to identify drugs based on the markings that are on them. You also want to make sure the client is has the right assessment, that you're doing the right documentation. I believe you went over these, so I'll pull these up again in class next week, but on a more concise handout, and I'll send it out just in case it didn't get covered in lab. These are in the textbook as well. Right to education, we want to make sure that the client the client has the right to refuse the medication, but we have to make sure that they've got the right education, that their decision that they're making their possibly a refusal on was an informed decision based off the education that they were given proper education. So right evaluation in follow-up of the drug, and the client does have the right to refuse the medication. Nurses' rights when giving medicine, you have the right to a complete and clear order. If you cannot read the doctor's order, what are you supposed to do?
Clarify or call.
Clarify. Clarify it with who?
The doctor.
The doctor or the provider that wrote it, yes. The correct answer is never going to be walk around the unit and see how many people think it's this, how many people think it's this. You want to make sure that if there is any question in the order, you want to call the doctor or the provider. Yes, absolutely. You have the right to have the correct drug, the correct route or form, and dose dispensed. You have the right to access to information to look up the medication if you're not familiar with it. The right to have policies to guide safe med administration, and we'll talk more about this in our Safe Culture of Med Practice assignment. Right to administer medication safely and to identify system problems. The right to stop, think, and be vigilant when administering meds. You are the client's last line of defense before that pill goes in their body. So this is serious stuff as far as delivering and administering the medication. Even if the doctor ordered it and there was an error in the order, you gave the drug, you are liable because you are the one that administered the medication. And we'll talk a little bit more about medication errors and medication safety because it is a big current topic in healthcare. As part of the National Patient Safety Goals, the Joint Commission, which is what the TJC, and they have a website here, jointcommission.org, they announced in 2004 that accredited organizations may no longer use selected abbreviations, and they actually have a list that is called the Do Not Use list that you can view. We have, it's in the Davis Drug Guide as well as in our textbook as well. You can review some of the practices at the Institute for Safe Medication Practice at this website. And then black box warnings are also where we have known adverse effects that occurred to populations taking medications that could not directly be associated to the drug, but they were identified in the study as having a potential correlation. As we talk about certain drug classifications, I do make a point to show you black box warnings that are current. So again, Joint National Commission, they, as part of their National Patient Safety Goals in 2013, there's a process called medication reconciliation. This is a process that when a client comes into a facility, they have a list of their medications that they're currently on that is compared to medications that may currently be prescribed, whether they're getting admitted to the hospital, whether they're going to a doctor appointment, a specialist appointment. It's a way of tracking to make sure that the medications that they're on are safe together. It's a comparison based on what were they taking and what do we want them to take to make sure that there's nothing is left out, there's no duplication, and there's nothing that's going to cause, a harmful interaction. And this is a list that the client is supposed to keep updated and communicated to their care providers. And this, this gets tricky when you got clients that are going to multiple providers and maybe getting different things. And if the lines of communication aren't kept open or congruent, medication errors can occur. I just thought this was cute. We do know that when pills are combined, we do have an increase in client compliance. So, but again, just thought that was a cute way of putting that into the perspective. We'll talk about that dosing of medications as we move forward in the lecture.